So hello, welcome. I'd like to welcome you all, everyone in the Unacademy platform. So this is Unacademy platform, and I'm sorry I will not be able to write today because I just missed this pen, the stylus of this Wacom. So it will be very difficult to write basically. And I would like to welcome you in at the platform of Unacademy, and it is Let's Crack NEET PG. Now myself, I'm Dr. Anil Sharma, and I'm a MD pathologist. Okay, I'm a MD pathologist from AIIMS Delhi, and we have been together for some time now. Now coming to the firstly, I'd just like to welcome you all in our family. And if anyone of you want to be part of our family, basically you can download our learning app. So Unacademy learning app. So this learning app basically you can install in your phone. You can type Unacademy learning app in Google, and just you can install this app. It is around 25 MB. Now after installing, you can be our subscriber. You can get our plus subscription or iconic subscription. So now plus subscription basically gives you live classes. The live classes like this one is a live class. So similarly, so many teachers of different faculty, they provide you with live classes basically. And at present, live classes are very, very important because the trend of questions which are asked in exam are typically more conceptual, are typically more basic, and are also more image based. And to teach or to clear some concept, to teach image based question answer, you need some a platform where you can show lot of images, when you can show lot of conceptual approach to that thing, and that may and obviously this online classes makes that thing very easy. Okay, and especially for people like me, it makes quite easy because I'm very bad in drawing. Okay, when I used to draw heart also, I used to draw गोल बना के ये artery है ये तो, so it's a very difficult and it becomes very easy to explain by using images from different platforms on the live classes. You can give live test and quiz, you can have batch courses, and you can also there is a structured schedule of each and every topic and each and every subject matter. And iconic, you get a gift, that is you get prep ladder. So basically this is a gift which you get, a prep ladder, and in prep ladder you get video lectures. Okay, video lectures, question banks. So the question bank contains all the past year questions of NEET PG, AIIMS, PGI, and everything. Okay, now basically called as INICT. So basically this is a very, very gold point. Then you have a rapid review courses. Even in Unacademy, most of the teachers they take a marathon classes mostly of 10 hours and 12 hours and complete the complete subject matter at one go. So there is a rapid revision courses you can get, handwritten notes of toppers and plus teachers you can get in iconic section. So this you can, for subscription, what you need to do is just there's a small amount of payment. So the iconic, for 12 months you need to pay 55,000 rupees, but you have a catch here. So the catch is that if you apply the coupon code, okay, this like my Anil live, so you each teacher or everyone even Unacademy platform itself have a promo code. So you can use any promo code. If you use my promo code, you will be getting 10% discount. 10% discount is in every promo code, so you can use this code or you can use other code also, any code which benefits you. Okay, so you just use this code. You in next 12 for 12 months you can get subscription at the rate at price of 49,500. Now that is especially giving you 5,500 discount. That means you are paying 4,125 per day, which is basically not a huge amount when you get a huge amount to study. Okay, so lot of thing to study, lot of test series and all. So this is not a huge amount because see, there are a lot of faculties like me, there are a lot of faculties, and obviously Unacademy also need to pay them. And obviously see the class which I have made today, that also I have taken so much of reference from different places, and obviously it nearly took me whole day to prepare a class. So obviously they also need to pay them, and obviously some part we also need it. So that is see, give and take phenomenon everywhere. But as a student, when you think about yourself as a person, okay, don't think as a large scale, but when you think about yourself only, monthly 4,125 rupees, and you are getting lot of classes. If I'm giving you something in today's class also, remember one or two thing will be such things which will obviously will be asked in your exam, and might be that one thing is one thing you will get from only me. Okay, maybe I might be teaching you some one specific point that other teachers might have escaped. Okay, and that thing comes in your exam, so that becomes very, very important. So basically it's not a big amount. If you like, you can just subscribe. You can subscribe with my promo code, or there are a lot of teachers. Okay, so you can subscribe plus subscription. Basically you can get with 1 month, 3 months, 6 months, 12 months, 18 months, 24, 36 months, and basically for 24 months you will be paying 40,000 rupees. Again, applying my promo code, you will get a discount of 10%, and for 24 months you will be paying 36,000. That gives about 4,000 discount, and you are just paying 50 rupees per day. So you are just paying 50 rupees per day, and you are getting all the live classes of, and you can just interact with the teachers and special classes. It is a win-win deal. Okay, in win-win deal. And why I am saying you this, the last factor for it is here the faculty. Okay, so you have a good, very good amount of faculty, very good teacher of faculty like Dr. Pawan Kandhari. So he's basically a good surgeon who has a very good academic record. Similarly, Dr. G Rajesh, Dr. Preeti Sharma. So now she is like for pathology, she is a wonderful teacher. Her classes you can take, you can just search Dr. Preeti Sharma and just take her classes of staining, renal also. She have a very fine way of teaching anything. And Dr. Zainab Bora, so she is the best in radiologist what I have seen. Okay, so you have a very good faculty, mentors over here, and basically they will help you, and basically I myself will also help you to get or crack NEET exam. So let's crack it together as a family, and I like to welcome you in the world of pathology now. So basically what we have done till now, we have done about different types of myeloma. We have classified plasma cell neoplasms. Okay, we have classified plasma cell neoplasm. In that we have done about MGUS. Okay, so there is one more thing left which you need to know about, that is smoldering myeloma. And basically in smoldering myeloma, this both criteria should be met. That is your serum monoclonal protein, that is M proteins, must be greater than 3 gram per deciliter, or now remember this is and, can also be or, bone marrow plasma cell greater than 10%. Okay, remember in MGUS bone marrow plasma cell is less than 10%, but in smoldering myeloma the bone marrow plasma cells are greater than 10%, which is seen in multiple myeloma also. I'll not be able to write, please, I'm sorry for that. Then you will have no end organ damage. Okay, so no end organ damage, this is the basically this is the high yield point here over in smoldering myeloma. This feature you also get in multiple myeloma, but in smoldering myeloma you don't get end organ damage. Okay, end organ damage basically is explained by CRAB. Okay, CRAB. We have discussed about this complete full mnemonics also. Again, when I will teaching multiple myeloma, I'll talk about CRAB again. Okay, so this smoldering myeloma basically doesn't require any type of intervention, but yeah, you need to surveillance or close surveillance of the patient is very, very necessary. Okay, so close surveillance by you need to know by serum electrophoresis. Okay, serum protein electrophoresis, CBC, creatinine and calcium. So you need to do every 3 to 4 months. Okay, every 3 to 4 months, and skeletal survey annually to pick any kind of asymptomatic bone lesion. So this is very much important in case of smoldering myeloma. So let's come today about multiple myeloma. So we'll discuss about multiple myeloma or plasma cell myeloma, PCM. It is also called PCM, not paracetamol. It is PCM, plasma cell myeloma. Okay, also called as PCM. So plasma cell neoplasm, basically plasma cell neoplasm, we have already talked about that there is monoclonal proliferation of plasma cells. We talked about yesterday in the just basic class which we did before this, and now they are basically associated with lytic bone lesion. We have talked about this. So this is very important, lytic bone lesion. So there will be bone lesion will be lytic. Okay, not basically not osteoporotic, it is a lytic lesion. Okay, it will be lytic lesion, not sclerotic, lytic lesion. And then there will be hypercalcemia, renal failure and acquired immune abnormalities. Okay, so multiple myeloma is associated with this. So bone marrow will show numerous plasma cells. So this is basic features which you see in multiple myeloma. Now, what are the clinical features? We have already discussed about this. So clinical features, CRAB. So CRAB is basically most important point which you need to remember in case of multiple myeloma. So CRAB, C stands for hypercalcemia. C stands for hypercalcemia. Hypercalcemia, basically calcium greater than 11 milligram per deciliter. In India, basically 10% you can see in or 10 milligram per deciliter is known as hypercalcemia. So when calcemia increases, then hypercalcemia, so you will have cardiac dysarrhythmias as clinical findings. You will have constipation as clinical finding. You will have nausea. You will have decreased GI motility, okay, because calcium basically in cardiac, we know very well, calcium is basically responsible at the at place of what you call it, calcium is important at the plateau phase, okay, plateau phase. And basically then again what you will have change in the mental status changes, lethargy, confusion and memory loss. These all are because of hypercalcemia, okay. So these are because of hypercalcemia. So this is manifestation, clinical manifestation of hypercalcemia. You will have vomiting, nausea, constipation, which is related to GI, okay, because of decreased GI motility. In cardiac there will be cardiac dysarrhythmias, and in neurological there will be mental status, lethargy, confusion and memory loss. So these all are associated with calcemia. Then you have renal dysfunction, R, CRAB. R for CRAB is renal dysfunction. And basically renal dysfunction, again see, one, it was because of hypercalcemia. Another, obviously there is light chain deposition, urate nephropathy, amyloidosis and toxicity. But basically R is related to serum creatinine greater than 2 milligram per deciliter. So how do you know that renal dysfunction has occurred? You see serum creatinine greater than 2 milligram per deciliter, or the creatinine clearance is less than 40 milligram per minute, okay, 40 milliliter per minute creatinine clearance. That is important, 40 milliliter per minute. You can be given any two of the options, okay, any two of the options in your exam. So this is renal dysfunction. So C for calcemia, that is hypercalcemia. R for renal dysfunction, that is for creatinine and or creatinine clearance, okay. Then basically another important thing is you can also see in multiple myeloma, you can see cast nephropathy. Basically in the collecting ducts, basically in the ducts, PCT and all, you can see amorphous concentric laminated casts, okay, you can see cast. So basically this cast nephropathy can also be seen in multiple myeloma. Then A, CRAB. For A is anemia. So anemia is mostly less than 10 gram per deciliter, or basically it is 2 standard deviation less than that of lowest hemoglobin, okay, 2 standard deviation less than that of lower standard of hemoglobin. And basically we consider, WHO consider 12 as low level. So basically 2 standard deviation low, that is less than 10 gram per deciliter, okay. And anemia, basically which type of anemia you will see normocytic normochromic anemia. Remember, normocytic normochromic anemia in case of multiple myeloma anemia. So bone pain. Now another thing you get is CRAB. B is basically related to bone, okay, and basically bone, it's not related to pain basically, but yeah, there will be bone pain which will then you, because of that bone pain is the most important clinical manifestation which you get in case of multiple myeloma, okay. So which of the following is the most important clinical manifestation? It is bone pain. And that for bone pain, whenever symptoms are seen of bone pain, basically what do a patient do? He will basically then go to a doctor. So what is your what are doctors what do a doctor do? So basically he will order for scanning, okay, he will order for scanning, and if greater than one lytic lesion is seen on the if there is after scanning, CT scan and all, then you again, that is a condition of end organ damage, okay. So basically now what you need to remember this, that bone pain is the most common symptom in myeloma. So remember, bone pain is the most common symptom in myeloma, and if there is persistent localized bone pain, then you can think that fracture can also occur, pathological fracture can also occur. And then the next common clinical problem in multiple myeloma is bacterial infection, okay. So bacterial infection, why bacterial infection? It's so easy to explain, okay. See, gamma proteins, okay, gamma proteins or gamma region. We know very well that when we do electrophoresis, we'll have albumin, alpha 1, alpha 2, beta 1, beta 2, and gamma. So in case of multiple myeloma, it is the gamma band which have increased and which becomes darker. Okay, so yeah, globulin, there are increased in globulin, but remember, if you just omit gamma, then what happens actually in multiple myeloma, you see hypogammaglobulinemia. Okay, you see hypogammaglobulinemia, or in another sense, M proteins, one type of immunoglobulin is formed in excess, but there is a decreased amount in others. Okay, and whenever there is a decreased amount of immunoglobulins, obviously then and hypogammaglobulinemia, it becomes easy for the infectious agent to infect the patient. Hence there are more kind of bacterial infection, and the most common is because of Staphylococcus pneumonia, Streptococcus pneumonia, Staphylococcus aureus, and Klebsiella. Okay, so the most common is because of pneumonia, Staphylococcus aureus, Klebsiella, and the most common infections which occur is basically pneumonia and pyelonephritis. Now this pyelonephritis is because of gram-negative E. coli. Okay, you remember this thing. So these are very important thing. Most important symptom in myeloma is bone pain. That you need to remember. Okay, now bone lesion, basically why they are caused? Because of proliferation of the tumor cells. Then again there is activation of osteoclasts that destroy the bone, and there is suppression of the osteoblast. Okay, that's why there is bone pain. Okay, now this osteoclastic activity, okay, osteoclastic activity is mediated by osteoclast activating factors and produced by the myeloma cells. So this myeloma cells produces, and remember, in bone lesion, basically you see lytic lesion. Okay, lytic lesion, you see lytic lesion. So for lytic lesion, hence radioisotopic bone scan is basically less useful in the diagnosis of multiple myeloma than the plain radiography. Okay, plain radiography is more helpful than the radioisotopic bone scanning in case of multiple myeloma, because here you are not seeing sclerotic lesion, but you are seeing lytic lesion. Okay, so CRAB, hypercalcemia, basically renal dysfunction, which is represented by creatinine greater than 2 gram per deciliter or greater than 40 milliliter per minute. Then you have anemia less than 10, okay, milligram per less than 10 gram per deciliter. Then you have anemia. Then you have CRAB, bone lesion. Basically bone lesion you are getting as how we are getting as bone lesion greater than 1 lesion per in the CT scan or MRI. Okay, it's mainly CT scan. So patient with myeloma, again see, patient with myeloma will have diffuse hypoglobemia. I already explained this. Okay, so this will result in increased destruction of normal antibodies. Okay, so this, because of this, there are chances of high infection rate in case of multiple myeloma. Okay, now see, we talk about what we said, that bone pain is the most common clinical symptom presented in case of multiple myeloma. Now what do you remember? Another thing is that hypercalcemia is the most common cause of renal failure. So renal failure is caused most commonly because of hypercalcemia. Okay, and another important thing what you need to remember is that tubular damages are associated with excretion of, see, remember, in multiple myeloma glomerulus is normal. In multiple myeloma glomerulus is normal, mostly it's normal. Okay, glomerulus is normal. Hence in multiple myeloma you don't see that much changes in your albumin. Okay, albumin में इतना changes नहीं आता. How, when will albumin में changes कब दिखेगा? जब glomerulus में problem आया. जैसे कि diabetic nephropathy. In diabetic nephropathy, obviously there will be problem in glomeruli, and hence there will be more secretion of or there of the albumin in the urine. Urine में albumin का ज़्यादा secretion होगा, ठीक है? But in case when we talk about our multiple myeloma, what happens? There is low hypogammaglobulinemia and M proteins are increased. Okay, so basically there are more of light chains are deposited, and because of that light chain deposition, what happens? There is more amount of tubular damage. Okay, so tubular damage basically is always or most commonly always present in case of multiple myeloma. ठीक है. So now remember, and this tubular damage, which it is early manifestation of this tubular damage is Fanconi's syndrome. Fanconi's syndrome is basically Fanconi syndrome, Gitelman syndrome. So you need to know about this Fanconi Gitelman, okay, in when you talk about tubular damages. Okay, so when we talk about tubular damage, we'll again discuss this. So it's basically type 2 proximal renal tubular acidosis. Okay, it's a type 2 proximal renal tubular acidosis. And remember, this is a very high yield point. Glomerular function is basically normal when you talk in case of renal, when you talk in case of multiple myeloma. Then again, when you are talking about renal diseases, then you need to talk about anion gap. Okay, so basically the anion gap decreases in this. Why anion gap decrease? So basically anion gap is what? Anion gap is basically total cationic properties minus anionic properties. Okay, so basically total cationic, that is sodium plus, and total anionic, that is chloride and bicarbonate. Okay, so now see, M protein is basically M component, or gamma protein or M component is basically a cationic. So what happen, this cationic will try to retain the chloride and sodium will go out, sodium will be going out. Okay, hence the anion gap will decrease. Okay, anion gap will decrease because this will become less and this will become high. So this less minus this high quantity will result into decreasing in anion gap. Okay, so now see, now there is loss of sodium, so sodium will be losing, there will be loss of sodium from the urine. So what happens? So there will be hyponatremia, but actually this is a pseudo hyponatremia. Okay, pseudo hyponatremia, because there is increased protein, M protein, also protein as a whole is increased. Okay, so because of that the water is also less there. Okay, so when you compare with that amount of water which have sodium, so according to that there will be no hyponatremia, but actually there will be hyponatremia. Okay, because sodium is losing out. Okay, through these channels. So that you need to remember. So you need to remember glomeruli are normal, tubular damage occur, and which type of tubular damage occur? It mostly occurs Fanconi syndromes. Okay, so Fanconi syndrome can be associated with your multiple myeloma. That you need to know. Anion gap decreases. Okay, so these are the different findings which you get in case of multiple myeloma. Other you can get like fatigue, already we have talked about. Nausea, vomiting we have talked about because of this hypercalcemia. This is because of hypogammaglobulinemia, recurrent infection. Fatigue again because of hypercalcemia. Bleeding and clotting disorders, this can be also associated with hypercalcemia. Neurological symptoms, hyperviscosity, okay, because of this immunoglobulin light chain depositions. Poem syndromes and peripheral neuropathy, this all can occur in case of multiple myeloma. Okay, so now coming to the evaluation, we have already done most of the part in the basic. I'm not going to complete explain kiya tha. So when you evaluate, what you do is you start with your blood, CBC. Okay, you do CBC, ESR. So CBC, ESR and peripheral. CBC we know by now. What we know CBC, so we get that normocytic normochromic anemia. ESR basically it's a chronic inflammatory disease like this thing, so there will be increase in ESR. And peripheral smear, so what you get in peripheral smear, I'll just explain you. Similarly, you do renal function test, serum calcium and uric acid to check about the end organ damage hua hai ki nahi hua. Then you just check for the serum albumin, okay, LFT, serum LDH. So serum LDH is basically more or less working towards or it helps in prognostic marker. Okay, skeletal survey again for diagnostic purpose. Serum beta 2 microglobulin, serum beta 2 microglobulin, again it's for prognostic factor you do. So serum LDH and serum beta microglobulin, these both are for prognosis. Okay, these both are for prognosis. For this, they don't help in diagnosis, but they are important in prognosis. Echo and Muga scan, bone marrow examination. Okay, you can do bone marrow aspiration and bone marrow biopsy. You can do thyroid function test. Albumin is to globulin reversal ratio, and obviously serum and urine electrophoresis. So serum and urine electrophoresis, they are basically most important test which you do in case of multiple myeloma, and they are used for screening. Okay, they are used for screening. Now peripheral smear, as I said, for peripheral smear what you see Rolex formation. Okay, stacking of the RBs, coin like stacking. सब ये coin जैसा stacking हो रहा है ना, एक के ऊपर एक coin के ऊपर दूसरा coin ऐसे आके बैठा जैसा लग रहा है. So this is basically your Rolex formation. This is your Rolex formation. So you get Rolex formation. So Rolex formation gives an idea that there is a problem with, there can be multiple myeloma. So this gives us about the idea. Agglutination, if there is agglutination, similar types of other finding is agglutination. So if there is agglutination, it gives us idea that there can be some problem with hemolytic anemia. Okay, that can be related to hemolytic anemia. So you need to differentiate. If there is Rulex, then you go towards multiple myeloma. So Rulex formation is the most striking features of blood smear, and it is related to the quantity and type of M protein. Okay, then you can also see leukoerythroblastic reaction can be observed in case of peripheral smear. Skeletal survey. So what do you use skeletal survey? So you see multiple lytic lesions. So multiple lytic lesion, rain drop lesion कहते हैं, ठीक है, rain drop lesion, RAN rain. So you get rain drop lesion. So here you can get RAIN. Rain. Sorry, I cannot write because I don't have this writing today. So there is basically you get multiple lytic lesion. Okay, so like raindrop lesion in the skull. Okay, then you get pathological fractures, and there will be osteopenias. Okay, so basically osteopenia. Now the most frequent site of the lesion in the decreasing order. So most frequent site is vertebra, then ribs, skull, shoulders, pelvis, and long bones. Okay, so long bones, the chances of the lesion going to long bone is very less. Common it is vertebra. Okay, it's common vertebra. So then another important investigation is serum and urine electrophoresis. So we have talked about this in yesterday's class also, that obviously when you do electrophoresis, it's on the basis of the charge, and obviously on the basis of the charge and mass and charge, and plus other factors like the medium, the temperature, the proteins, they will separate into two forms, that one is albumin and another is globulin. Okay, one is albumin, another is globulin. So globulin, again they can be alpha 1, alpha 2 globulin, beta 1, beta 2 globulin, and gamma globulin. Okay, so this basically, this first part is your normal thing, which is you can see, and this second part you can see a band in the gamma region, and this is a monoclonal component, and this is what you see in case of multiple myeloma. Gamma globin में band दिखता है. Okay, so this is normal SPEP, that this is alpha, this is albumin, this is alpha 1, alpha 2, beta 1, beta 2, and this is your gamma region. So in the gamma you can see your M spike. Okay, M spike if you see, then that is basically because of multiple myeloma. Chances there are high chances are that of multiple myeloma. So after doing serum protein electrophoresis, what you need to do is you need to know that which type of M protein, okay, which type of M protein has accumulated, whether it is IgG, whether it is IgM, whether it is IgE, or which type of mostly immunoglobulin has deposited. And for that, what you need to do, you need to do immunofixation. Okay, so basically this first chapter, this first one is showing you about the serum electrophoresis. So immunofixation comes combined with serum protein electrophoresis. So see, in this you see gamma component. So when you see gamma component in this, what you do immunofixation. So you do immunofixation for what? You do immunofixation for G, that is IgG, IgA, IgM, and kappa and lambda light chain. And so basically in this case, what you see, basically you see G type. So you see IgG type, and obviously you see a band in lambda. You see lambda, band in lambda. So basically you see IgG lambda type of immunofixation. Okay, so this is the deposition of IgG light chain. IgG light chain deposition can be seen. Now coming to the this is a seen in the urine, case of urine. So here you can see also here in the lambda region there is deposition. Okay, deposition in the lambda region. So then the third thing what you can do, so serum protein electrophoresis you can do immunofixation. Okay, then you can do so we did PS, we did skeletal morphology, we did about different markers, like we did serum protein electrophoresis, we did immunofixation, and now we are doing free light chain assay. So free light chain assay is basically, remember, normal kappa level is 3.3 to 19.4 milligram per deciliter, and normal lambda level is 5.7 to 26.3 milligram per deciliter. So what do you see? You see serum free light chain ratio. So normal serum free light chain ratio is 0.26 to 1.265. So anything, if there is less than 0.26 ratio, or if there is a ratio of greater than 1.65, so that is basically diagnostic for multiple myeloma. So serum free light chain ratio greater than 100 is basically known as So basically greater than 100 means greater than this 1.65, that is basically non-diagnostic of multiple myeloma. Then next thing what you can do is basically you can do bone marrow examination, where you can, in bone marrow we can basically see plasma cells. Okay, so plasma cells basically, when I have already said that normally there are less than 5% or less than 3% of plasma cells, but in multiple myeloma you get more than 10% of the plasma cells in the bone marrow. See, and then obviously we have already talked about Dutchess body. So Dutchess body, their Dutchess are basically your body which are nucleic, okay, nuclear, intranuclear inclusion. So Dutchess have C, so it's not cytoplasmic, rather it is intranuclear inclusion. Okay, and Russell's bodies are basically intracytoplasmic inclusion. Russell's bodies are intracytoplasmic inclusion, and Mott cells are basically numerous Russell body in the cytoplasm of a plasma cell. So this is a plasma cell. So this has a perinuclear half, your basically clock face nuclei, and all these are Russell's bodies. Okay, these all are Russell's body, and this internuclear hyaline globule type deposition in the nucleus, there are Dutchess bodies, which are seen in case of multiple myeloma. But remember, this is not characteristic. Yani if you are seeing Dutchess bodies or Mott cells in a biopsy, then you cannot say that it is a multiple myeloma. Yeah, but if in multiple myeloma there are high chances that you get Dutchess body and Mott cells. That is important. Okay, that is very much important in case of this drawing. And so basically then kidney, in kidney you can see bench zone proteins which accumulates as aggregate of eosinophilic material in lumina of renal tubules. So renal tubular reabsorption of bench zone protein is largely responsible for renal damage in basically PCM. So in kidney you can see basically bench zone proteinuria. Okay, then now what are the criteria for diagnosis? So the number one criteria basically is clonal bone marrow plasma cells must be greater than 10%. Okay, clonal bone marrow plasma cell should be greater than 10%, or the biopsy proven bony or extramedullary plasmacytomas is there. So either if there is basically bony or extramedullary plasmacytoma, okay, so basically intramedullary or extramedullary plasmacytoma, or if there are clonal bone marrow plasma cell greater than 10%. And what you need to know, you need to have any one of the or more of the CRAB features, and which are also myeloma defining events. Okay, myeloma defining agent. So myeloma defining agent is basically what you have. So 60 or greater clonal plasma cell on the bone marrow examination. Okay, serum involved to uninvolved free light chain ratio. So involved to uninvolved free light chain ratio, or it should be of 100 or more. Okay, so basically you need to remember that's involved to uninvolved free light chain. So you have involved free light chains are more than that of uninvolved this month. Okay, and there is more than one focal lesion. Remember, there is more than one focal lesion on MRI. Okay, so more than one focal lesion on MRI, that is at least 5 mm or greater in size. So that you need, that time you say that so this is basically MDE. Okay, so these are basically biomarker of malignancies. Okay, so basically defining basically they are myeloma defining events, so they are known as myeloma defining events. Okay, now coming to the immunophenotype. So what we have already talked about, that normal plasma cells, they are CD38 positive and CD138 also positive there. But so normal plasma cells are bright CD38 positive. Okay, when you do flow cytometry, they are bright CD38 positive. And also you need to remember that the monotypic neoplastic plasma cells they show cytoplasmic immunoglobulin positivity. Okay, and usually they lack surface immunoglobulin positivity is negative. Mostly the CDs are such as CD3 हो गया, CD4, CD8 जो भी CD है, they are membranous. Okay, they are membranous positivity, but in this case they will show cytoplasmic positivity in case of immunoglobulin. And mostly CD38 and CD138 are positive, but CD38 is basically bright in case of normal plasma cell, but in case of plasma cell, multiple myeloma plasma cell, CD38 expresses dimmer. Okay, CD38 expresses dimmer, and CD138 expresses brighter. Then another very important high yield point is CD19 is negative in this case. Okay, so basically the plasma cells, they are forming from the B cells, so you might think that B cells are positive for CD19, but there is aberrant negativity in CD19 in case of plasma cells, multiple myeloma. Okay, then another very high yield is CD56. So there will be positivity in CD56. So there will be CD56 positive, and another very high yield point is you can see CDs, that is cyclin D1 expression can also be seen. Cyclin D1 expression which is seen basically in case of mantle cell lymphoma. So cyclin D1 is seen in case of mantle cell lymphoma, or SOX11 can be seen in mantle cell lymphoma. So basically cyclin D are positive in case of mantle cell lymphoma, so they can be also positive, or they are also positive in case of plasma cell neoplasm, that is multiple myeloma. Okay, so cyclin D we know very well, it's associated with mantle cell lymphoma, and we know mantle cell lymphoma is translocation 11-14. So 11-14 translocation can be seen in case of multiple myeloma also. So now you are established with the diagnosis. You know that diagnosis is done. You have verified, you have immunofixed, you have done serum protein electrophoresis. Okay, you have done IHC. By that you have now diagnosed that it is multiple myeloma. Then what you need to do? You need to do some more investigation for staging purpose and prognostic purpose. So staging and prognostic purpose, what are the two major important investigation is beta-2 microglobulin and serum albumin level. Okay, so by beta-2 microglobulin and serum albumin level you can do staging also. So international staging of multiple myeloma is done by is helped by importantly two important investigations, that is beta-2 microglobulin and serum albumin level. You can also do FIS. FIS is mostly done for molecular characterization of multiple myeloma. So unka mutation kaun sa, and that molecular characterization will help in prognosis. Okay, that molecular characterization will help in prognosis. So basically for staging and prognostic, there are three important things which investigation which you need to do is beta-2 microglobulin, serum albumin level and FIS. Okay, so diagnosis is established. Now what you need to do? You need to do staging and prognostication. So see, what are different types of mutations which you see in multiple myeloma. So when I talked about MGUS, when I was talking about MGUS and even multiple myeloma also, so when you write multiple myeloma, so basically what you can remember is you can write M. Okay, you can write M. Multiple myeloma is MM basically. Okay, multiple myeloma is MM. So what you can see is here, and when you write MGUS, okay, so there will be similar type of in plasma cell neoplasm there will be similar type of molecular genetic categories you will see in case of MGUS or multiple myeloma. So remember, when you write MM, you can also write this way. Okay, this way you can write. So M can be written this way also. So when you write M this way, so this is like 11, and if you also see more clearly, this is like H. So basically what you need to remember is you need to remember one thing, that basically multiple myeloma is related to immunoglobulins. Okay, so immunoglobulin heavy chain, so there will be translocation of immunoglobulin heavy chain, and basically IgH immunoglobulin heavy chain is basically present on chromosome number 14. It is basically present on chromosome number 14. So from chromosome number 14, hence in basically what you do in case of multiple myeloma, you see translocation of immunoglobulin heavy chain, that is chromosome number 14. So for translocation chromosome number 14, you need one more chromosome. So basically see, one is this. When you write M, this 11, so there will be translocation of 11-14. So translocation of 11-14, and another important translocation is this U. When you write U, basically it is, or in multiple also, when you write MUL, the second one is U. So this MU, basically U is 4-11 translocation. Okay, 4-11 translocation, that is important. Okay, so multiple myeloma. So when you write multiple MILTI, you write U in the second, so the U is like 4, so there will be 4-14 translocation. Okay, there will be 4-14 translocation and 11-14 translocation. These are the two important translocation which you see in case of multiple myeloma. Okay, 11-14 translocation and 4-14 translocation. Okay, then other translocation which you can see is, again as I said, there will be immunoglobulin, Ig hemoglobin, IgH immunoglobulin translocation. So with 14 only there will be 6 and 12 also. So 6-14 translocation and 12 translocation can also be seen in case of multiple myeloma, but important one is 11-14 translocation and 4-14 translocation. Okay, so this was translocation, IgGH translocation. Now so 14 coming second, so there can be a translocation, that is 14-16 translocation also. Again this is very important translocation, 14-16 translocation. So this 14-16 translocation can also be seen in case of multiple myeloma. Okay, 14-16 translocation also can be seen. And other, as I said, when you write M, it looks like hyperploidy, so this is basically can be associated with hyperploidy also. So basically when you say about the mutation in multiple myeloma, so multiple myeloma can be associated with hyperploidy because M can be written like hyperploidy also. Then mutation can be also associated with IgH immunoglobulin, that is 14, that is 11-14 translocation, 6-14 translocation, 12-14 translocation. And also you can have mutation which is 14-16 translocation, but important one are 11-14 translocation and 4-14 translocation. Okay, so when you write U, this is U, so 4-14 translocation and 11-14. So when you write M, 11-14 translocation. These are two very important translocation which you see in case of multiple myeloma. So now if anything, see most common translocation क्या होगा, it will be associated with chromosome number, it will be associated with 14, that is it will be associated with chromosome number 14, that is it will be associated with immunoglobulin heavy chain, that is 14. So now anything where if there is translocation associated with 14 or if there is hyperdiploidy, okay, anything common, so these are the common thing you find, or these are the common mutation you find in multiple myeloma, so they have good prognosis or say intermediate prognosis. Okay, so very good prognosis or intermediate prognosis. And anything except that, so see translocation with chromosome number 14 is common thing, so that is good prognosis. But translocation except that like with 14, but there is translocation like 14-16 translocation, so that is bad prognosis. Okay, that will be bad prognosis because that is not common thing. Common thing क्या है, 14 के साथ ट्रांसलोकेट करना कॉमन है, लेकिन अगर 14 के बाय किसी और के साथ था, जैसे 14-16 ट्रांसलोकेशन या 16 के साथ ट्रांसलोकेशन हो रहा है, सो दैट इज बैड प्रोग्नोसिस. ओके, दैट यू नीड टू रिमेंबर. सो देन वी कैन डिफाइन लाइक अकॉर्डिंग टू प्रोग्नोसिस और अकॉर्डिंग टू रिस्क, you know. So high risk is basically, see, so low risk one are those common mutation which you see like in 11-14, 6-14, hyperdiploidy, so they are the common mutations you see. Okay, and even 4-14 with the intermediate risk, this is a common mutation. Okay, deletion 13 is again you can see commonly, and hypodiploidy common mutation, so they have either very good or intermediate risks. Okay, but you see this deletion 17p, translocation 14-16, so this is not translocation 14-6, but the translocation 14-16 it has a bad prognosis. Translocation 14-20 has bad prognosis. GP high risk signature, they have also high risk prognosis. Okay, so there are high risks, so standard risks, intermediate risks and high risks. Okay, now as I said, serum albumin and beta-2 microglobulin, they are associated with intestinal staging system. So how do you stage this? You stage as stage 1 and 3. So remember stage 1 is associated with albumin and beta-2 microglobulin. Okay, so stage 1 basically is when beta-2 microglobulin is less than 3.5, you say it's stage 1. Okay, and or when albumin is greater than 3.5, when albumin is greater than 3.5 and beta-2 microglobulin is less than 3.5, you say it's stage 1. Okay, for stage 2 let's read it a little later. So if you just remember stage 1 is with 3.5, serum albumin greater than 3.5 and beta-2 microglobulin less than 3.5, that is stage 1. Stage 3 is only associated with beta-2 microglobulin, that is beta-2 microglobulin greater than 5.5, that is stage 2. So now stage 3. Now stage 2 क्या रह गया, something between this 3.5 to 5.5. So basically when you are seeing that beta-2 microglobulin is between 3.5 to 5.5, okay, 3.5 to 5.5, okay, then you say, or serum albumin is less than 3.5 or serum albumin is less than 3.5, that is stage 2. Okay, so this and this. So this and this both are present, then you see is stage 2. Or you can say if beta 2 microglobulin is less than 3.5, then also what you see, you can see that is stage 2, okay, and serum albumin is less than 3.5, then also you see is stage 2. So stage 2 is basically staging is basically associated with beta 2 microglobulin and serum albumin. So you just remember that if beta 2 microglobulin is less than 3.5 and serum albumin is greater than 3.5, it is stage 1. If beta 2 microglobulin is less than 3.5 but serum albumin is greater than or is also less than 3.5, then it is stage 2. And if beta 2 microglobulin is between 3.5 to 5.5, then it is if greater than 5.5, then you are diagnosing it as stage 3. Okay, so staging, for staging what is important? Beta 2 microglobulin and serum albumin is important. For prognostic value, obviously your molecular markers, they are important. Okay, now prognostic factor, so which all thing will help in prognosis? Albumin, beta 2 microglobulin, so they will have in prognosis. Okay, high amount of beta 2 microglobulin means stage is high, okay, prognosis is bad. Okay, and low amount of albumin is also, you can say, prognosis is bad. Then coming to the cytogenic abnormalities, we know very well bad prognosis if there is deletion of 17p or there is abnormality of chromosome 14, that is 14-16 translocation, or gain on 1q can also have a bad prognosis. Okay, and poor performance status have also poor prognostic factor. Now what is the pathogenesis, how this is occurring? So basically, you know, pathogenesis is whenever there is a stem cell, you will have a bone marrow stem cell, and that bone marrow stem cell, it interacts with the plasma cell either via cellular matrix, okay, extracellular, either they interacts via cellular matrix or they interacts with adhesion molecules. Okay, they interacts with adhesion molecule, and what this will do, this will create a microenvironment. So remember, a microenvironment is created in case of maximum tumor. In case of Hodgkin's lymphoma also microenvironment is created. In case of this multiple myeloma also a microenvironment is created with the release of different mediators. Okay, so we have talked about this in our neoplasia classes. So different mediators are releases. Okay, so these mediators when released, what they will do, they will activate different cycles. Okay, they will activate different pathways. Okay, pathway of growth of the tumor cells. Okay, pathway of growth of the tumor cells. So now what we have done in our general class, what happened? So whenever there can be problem with the growth factor, so there can be problem with these are the growth factor receptors or growth factor. So what happened? The tumor can act like that there is continuous activation of these growth factors, and there is continuous activation of this growth factor receptors. Okay, now this activation of growth factor receptors, they will result into basically activation of RAS pathway, and basically this activation of RAS pathway will activate RAF and PI3K pathway. Okay, so this is basically tyrosine kinase receptor or tyrosine kinase signaling pathway, and this pathway is very, very important when you talk about pathogenesis of any tumor. Okay, when most of the tumors are associated with the pathogenesis by this tyrosine kinase signal pathway. Okay, so basically there can be problem in the growth factor. आपके पास growth factor बार tumor basically specifically growth factors बना रहा है, जब वो हमेशा बनाता ही रह रहा है और आपके growth factor को कमी नहीं है, तो there will be regular activation of these growth receptors. There can be this problem in mutation in these growth receptors. There can be mutation in basically this downstream pathways, like mutation in a RAS pathway, mutation in RAF pathway, PI3AKT pathway. Okay, so this all pathway, so mutation in this all pathway, they will continue this cycle and hence will responsible for the cell growth. Same thing happen in case of multiple myeloma. So here see, this is this cell is basically your bone marrow stem cell, and whenever this bone marrow stem cell, what happens, it interacts with the plasma cells or multiple myeloma cells, else via either extracellular matrix or by adhesion molecules. Okay, so whatever the method, when there is interaction of this cell with these receptors on the stem cells, what happens, they will activate NF-kappa B pathway, and this NF-kappa B pathway will help to secrete these cytokines. Okay, and basically these adhesion molecules, they can also activate this PI3K pathway, and this all pathway, PI3K pathway, RAF pathway, JAK kinase pathway, this all pathway are responsible for growth. Okay, growth, cell growth. So basically these different cytokines like interleukins, vascular endothelial growth factor, insulin like growth factors, SDF1 alpha, what they will do, they will increase RAF and JAK pathway, and adhesion molecules will increase PI3K pathway. Okay, and all this pathway, what they will do, finally they are responsible for proliferation. They are responsible for proliferation, they are responsible for activation of cell cycle, okay, and they are responsible for migration and all. So this is basically the major pathway of development of multiple myeloma. So basically there are multiple steps for development of multiple myeloma, as we have talked about, like MGUS, monoclonal gammopathy of uncertain significance, and intramedullary and extramedullary multiple myeloma, and plasma cell leukemia. So see, remember, so they start with hyperdiploidy. So we have talked about that there will be hyperdiploidy will be found, and see, remember, hyperdiploidy is found in complete pathway. So this is basically, you know, more than 90 to 95% or maximally you must of the multiple myeloma, all of the multiple myeloma, they come via MGUS. Okay, MGUS से होता हुआ आता है. See, and this hyperdiploidy which is present in basically from MGUS to the plasma cell leukemia in each and every type of leukemia, this proves that obviously MGUS is a pre-malignant condition which can convert itself into plasma cell leukemia. Okay, and basically see, non-hyperdiploidy malignancy, we have talked about 11-14 translocation, okay, 4-14 translocation, and 14-16 translocation. These all are non-hyperdiploidy translocation which can be seen inside cytogenic abnormalities. Okay, and there are also abnormalities in cyclin, D1, D2, D3 abnormalities, and obviously there can be abnormality in these different pathways, RAS pathways and FGFR3 pathways, and obviously TP3 pathway and MYC dysregulation pathway, which are more common in case of plasma cell leukemia. Okay, and obviously there are problem with bone reabsorption, and there will be angiogenesis will also increase in case of leukemia. Whenever the multiple myeloma or leukemia starts increasing, there will be more and more angiogenesis, because angiogenesis, tumor cells will require blood vessel or blood to survive. Okay, and there will be more and more bone reabsorption. Tyrosine kinase we have talked. So basically this is the major type of clinical criteria, major type of clinical things which you see in case of multiple myeloma. Okay, so now how do you manage multiple myeloma? So for the management of multiple myeloma, see, you have main goal is for the prolongance of the survival and better quality of life. And there are two methods of treatment. That is, one is systemic therapy, another is supportive therapy. You give supportive therapy, that is you just try to prevent the symptoms, and one is you try to kill the disease myeloma cells, and one is basically you try to give symptomatic relief. Okay, so there is systemic therapy and supportive care. So now what, this is this is from your Harrison's, and you need to know these are the class of drugs which are used. Like there are immunomodulator agents. So like thalidomide is a very common immunomodulator which is used in case of multiple myeloma. Then you have lenalidomide and pomalidomide. So these are another lenalidomide and pomalidomide are other class of drug. So you select either thalidomide or lenalidomide or pomalidomide. Mostly you select thalidomide or lenalidomide. Okay, see that these are the two important drugs which are used. So if you have a newly diagnosed case, multiple myeloma, then you mostly select thalidomide. Okay, so for newly diagnostic case you select thalidomide, and if there are relapse case, then you select lenalidomide. Okay, you select lenalidomide in relapse cases. And in case of protease inhibitors, what are major drugs are bortezomib, carfilzomib, okay, carfilzomib, and ixazomib. Okay, so these are the most of the important drugs. So remember here, these are the important protease inhibitors. So most of them are protease inhibitors are like IV, given IV. Okay, IV, and remember ixazomib is the first type of oral which is given as a protease inhibitor. So ixazomib is a first oral drug, protease inhibitor drug, which can be given orally in case of multiple myeloma. So remember, in the newly diagnosed case, it is bortezomib are used in newly diagnostic case, and obviously carfilzomib and ixazomib, they are used in the case of relapse. Okay, Then basically there are antibodies like daratumumab and elotuzumab. Okay, elotuzumab. So these are daratumumab and elotuzumab. They are antibodies, and basically they are both are used in case of relapse case. So in newly diagnosed case, what you can use? You can use thalidomide, and you can use bortezomib, and you can also use an alkylating agent like melphalan. Okay, you can use alkylating agent like melphalan. So basically then also there are histone deacetylase inhibitor, SDC inhibitors, histone deacetylase inhibitors. So SDT inhibitors like panovinostate. Okay, so panovinostate are the histone deacetylase inhibitors. So they are also used in case of relapsed cases. And there are alkylating agents like melphalan, cyclophosphamide, and bendamustine. So these all are also alkylating agent which can be used in case of, so basically melphalan can be used in newly diagnostic case, and cyclophosphamide can also use in newly diagnostic case. And obviously steroids are given in all stages. Steroids are always given with all these drugs. So these are some of the important drugs which are used in case of treatment of your multiple myeloma. Now you can read this from your Robbins. Okay, you can read this from your Robbins. This table is in your Robbins, not in your Robbins, it's in Harrison. So the basically very important table which you can read in your Harrison. Now what are the mechanism of actions of this drug? Okay, so basically here mechanism of action is also used, like thalidomide is an immunomodulator, protease inhibitors. So bortezomib is a protease inhibitors. Antibodies are basically forming monoclonal antibodies, daratumumab and elotuzumab. Okay, so panovinostate is histone deacetylase inhibitors. So these are the mechanism of action. So basically when you talk about mechanism of action, what you need to know, sir, suppose this is a plasma cell and it is interacting with the bone marrow stem cell. We have talked about this. Okay, so basically there are different drugs like daratumumab. So this daratumumab is a basically monoclonal antibody, and what it does, it will inhibit this CD40. Okay, CD40, it will inhibit the CD40 receptors. Similarly periphosin, it what it will do, it will inhibit this AKT pathway. It will inhibit the AKT pathway. And basically similarly what this elotuzumab will do, elotuzumab will basically inhibit the growth factors or this receptors, CS1 receptors, that is SLAM F7 receptors, or basically they inhibit the CD138 receptors. Okay, CD138 receptors. And basically this bortezomib, it will inhibit the NF-kappa B pathway. Okay, NF-kappa B pathway को inhibit करता है. And thalidomide, it will inhibit the angiogenesis pathway, which will not lead the tumor, it will defect the angiogenesis, and hence tumor can't get blood supply and all. Okay, so this is the mechanism of different types of drugs used in multiple myeloma. Now multiple myeloma patient, basically what you need to do, there can be looked those patients who are transplant eligible, and those patients which are not transplant eligible. So those patients which are not transplant eligible are greater than 65 years and they have comorbidities. So in transplant eligible patient, what you do, you take induction therapy, you then do stem cell transplant, and then give maintenance therapy. But in multiple myeloma, those are not transplant eligible. What you do, you just give induction therapy and provide maintenance therapy. Okay, now response evaluation. So you say it is a complete response when there is negative immunofixation, no immunoglobulin deposition is seen, there is disappearance of any soft tissue or plasmacytoma, and less than 5% of plasma cell in bone marrow, then you say it's a complete response. And very good partial response, you say when you have greater than 90% reduction in the paraproteins, urine M protein level are less than 100 mg per 24 hour, plus paraprotein detected by immunofixation and not by electrophoresis. So by electrophoresis you don't detect paraprotein, by immunofixation still you are getting paraprotein. This is a very good partial response. Okay, then what is partial response? So partial response is basically when you have greater than 50% reduction in M protein in the serum, or greater than 90% reduction in M protein in urine, or less than 200 mg per 24 hour. Okay, so very good, you have less than 100 mg, but in partial responses you have less than 200 mg per 24 hour. Now progressive disease, what is that? At least 25% increase in paraprotein, increase of at least 5 gram per liter, and development of new bone lesion or plasmacytoma or hypercalcemia is what you need about progressive disease. Okay, so there is complete response, very good partial response, and basically your progressive disease. So this thing you need to know, you can be asked in your exam. Okay, So what are the possible induction regimes which you use? Okay, so as I already discussed from that table also, like in the transplant eligible patient, what you do, you use 3 drugs that we have already talked about, that you give bortezomib and dexamethasone. Steroid is always given. Now you can use one of the drugs like lenalidomide or thalidomide. Okay, newly diagnosed case you can use this, or you can use cyclophosphamide for 3 to 6 cycle. Then you can give autologous stem cell transplantation, or you can also use 2 drug cycle, and then you can give autologous stem cell transplantation, and then you give maintenance dose with thalidomide or lenalidomide until progression or intolerance is developed. Okay, so that you can you follow this type of treatment in case of transplant eligible patient. So what are the toxicities of these drugs? Let's say peripheral neuropathy is highest with thalidomide. Okay, so most of the toxicities are high with thalidomide. Okay, most of the toxicities are high with thalidomide, like peripheral neuropathy, fatigue, constipation, even neutropenia, they are high with thalidomide. Okay, and basically thrombocytopenia is not even seen with thalidomide, it is high with bortezomib. Okay, it is high with bortezomib. Thrombosis can be seen with thalidomide again, and infection can also be seen high with thalidomide, lenalidomide or bortezomib. Okay, so this is basically toxicity to induction therapy. So now in transplant ineligible patient, what you need to do, you need to give 3 drug induction, and that also what you do, you give either melphalan, prednisolone or thalidomide for 6 to 12 cycle, or you can give melphalan, prednisone or bortezomib for 9 cycles, or you can give melphalan, prednisolone or lenalidomide, okay, for 9 cycles, followed by maintenance with lenalidomide until progression or intolerance. Okay, if 2 drugs induction, what you can do, you can use bortezomib or dexamethasone for 8 cycles, or you can use lenalidomide and dexamethasone until progression or intolerance for a transplant ineligible patient. So now maintenance therapy, it will obviously, we know it will run for longer period of time. There will be prolonged overall survival and concern regarding secondary primary malignancy in patient with maintenance therapy. Okay, but again your benefit outweighs the risks, and what you give in maintenance therapy, you can give lenalidomide and dexamethasone, or you can give lenalidomide and bortezomib. Okay, so you can give lenalidomide and bortezomib. So now what are the options of treatment in the presence of comorbidity? Like if you have renal failure, so in the renal failure, what you can give bortezomib and dexamethasone and cyclophosphamide. So you have removed thalidomide or lenalidomide. Okay, then in case of thromboembolism, you can give melphalan and bortezomib. Okay, thromboembolism also very high in thalidomide. And in peripheral neuropathy is very high in case of thalidomide. So what you can give melphalan and lenalidomide. Okay, you can give melphalan and lenalidomide. Okay, so basically melphalan, prednisolone and lenalidomide can be given. So these are the cases when you give in comorbidity cases. Now in elderly patient, what you can give, so you can give elderly patients bortezomib, melphalan and prednisolone MBB therapy. Okay, or you can give melphalan, prednisolone or thalidomide. Okay, and lenalidomide and melphalan and prednisolone can be given in case of elderly patients. Okay, so now no treatment is over with when you don't talk about newer drugs. So these are some of the newer drugs which have been seen. So whichever topic you study, okay, just try to study the new drugs in that category. Okay, so like in multiple myeloma also, so basically I'm just integrating the subjects. Okay, so basically all this treatment you can see in case of your multiple myeloma treatment in your Harrison. Okay, you just go and study your Harrison. Most of the drugs have been given in Harrison, and most of the teaching is from your Harrison. So basically I have completed the topic. आपका medicine का भी हो गया, इसमें pathology का भी हो गया, pharmacology का भी हो गया. So that will help you to complete this topic at one go. You don't need to go to different books and different places like pathology में pathology part पढ़ा, फिर medicine पढ़ा. No, integrate the subject. Okay, so I'm trying to integrate. So this is basically your pharmacology part, and these all are the newer drugs. These are the newer drugs which you can give in case of multiple myelomas. Okay, these are the newer drugs which you can give in case of multiple myeloma. So multiple myeloma case में these are the newer drugs. So say like selinexor or called as Povio, you can give selinexor. So selinexor is basically a new type of multiple myeloma drug, and it has been approved in 2019 only. Okay, so this is a very important, this can be a new question in case of your multiple myeloma, or in case not only multiple myeloma, newer drugs. Okay, एक टॉपिक होता है फार्माकोलॉजी में जहाँ पे 1 से 2 या 2 से 3 क्वेश्चन हमेशा न्यू ड्रग्स के बारे में पूछा जा सकता है. ओके, तो सेलिनेक्सोर कैन बी योर अनदर न्यू ड्रग. नाउ व्हाई इट इज इंपॉर्टेंट? बिकॉज दिस drug is a newer drug for multiple myeloma, and what is its mechanism of action is, so they can ask you mechanism action, selective inhibitor of nuclear transport. Okay, seen, it is selective inhibitor of nuclear transport, and it is an FDA approved for what? RRD disease. Okay, relapse and refractory disease. So it is a FDA approved drug for not primary cases but for the relapse and refractory disease, which was approved in July 2019. Okay, it can be combined with dexamethasone and used to treat people who have tried at least four previous therapies. Okay, so it works by blocking XPO1, a protein that allows cancer cell to thrive. Okay, so basically XPO1 protein is helping the cancer cells to thrive. Okay, the XPO protein, and this selinexor, what it does, it will inhibit that XPO. Okay, so hence its name is XPO-vio. Okay, povio, it is name basically XPO, so it inhibits XPO1. Okay, so this can be your exam question. Basically this type of question you can get in your AIIMS exam. Okay, now coming to another important new drug is elotuzumab. Okay, elotuzumab. Okay, so elotuzumab is nothing but, again, what it is an anti-CS1 antibody. Okay, anti-CS1 antibody and cell surface 1 protein antibody. CS is cell surface 1 protein antibody, and this is CS1 is highly and uniformly expressed on the multiple myeloma cells with restricted expression on other cells. So this CS1 is, they are highly expressed on the multiple myeloma. We have talked about this CS1 antibody, which is highly expressed on multiple myeloma, and this elotuzumab will inhibit this thing, and hence there will be this multiple myeloma cells are mostly killed. So this is also used in relapse and cases. Okay, this relapse cases, this also used in relapse cases. So basically relapse refractory multiple myeloma में use होता है ये भी, relapse refractory multiple myeloma in the combination therapy. Okay, then you have another drug which is there is also newer drug only, daratumumab. So remember this daratumumab, again this is anti CD31 antibody. Okay, so CD38, so anti CD38. Now you just that's why I showed you this drawing. Okay, that's why I showed this drawing to you. So basically see here, this is C1 surface cell. Okay, surface cell anti C1 or SLAM F1 antibody. So basically elotuzumab will act on this here, and see daratumumab. So this is basically the myeloma cell have CD31 receptor. So daratumumab will inhibit in this receptor. Okay, so that's why I showed you this drawing, so that it becomes easy to understand the mechanism of this newer drug, elotuzumab, daratumumab. Okay, so this is important, you think about this treatment. Okay, so the newer drug you need to know. So these patients, so this also used in relapse or refractory multiple myeloma. Okay, and basically the efficacy of this drug is based on the serum or urine M protein component analysis. Okay, 49 to 64 reduction in serum M protein component and 80 to 97% reduction in plasma cell. No major adverse effect are seen in with daratumumab. Okay, then another important drug is isatuximab. Okay, isatuximab basically it's an again monoclonal antibody which works similar to daratumab. Okay, it also acts, or it also inhibits CD38 of plasma cells or multiple myeloma cells, used in combination with pomalidomide and dexamethasone, used in those who have tried at least 2 other therapy. It also targets CD38. Okay, that you know very well. Then you have ixazomib. Okay, or nilnaro. So basically what is important about this drug is it is the first protease inhibitor. So it's the first and only oral protease inhibitor. So which of the following is oral protease inhibitors when you are asked? So basically ixazomib is the first and only oral protease inhibitor that FDA has approved for multiple myeloma. Okay, so protease are the enzymes complex that help cancer cell recycle proteins they need to grow. Okay, so basically they inhibit this protease. Ixazomib, it's an oral drug. So ixazomib is a protease inhibitor drug which is oral drug. That is again important in case of this newer drug. This is also a newer drug. Okay, so combined with lenalidomide and dexamethasone, used in people who have tried at least 1 other myeloma treatment. Another drug is it's panobinostate, okay, अथवा feridac. So they are histone deacetylase inhibitors, okay. They are histone acetylase dehydrator, and they are the first of a class of drug called, so they're the first histone acetylase inhibitor which have been introduced for the treatment of multiple myeloma. This also combined with bortezomib and dexamethasone, okay. So this histone deacetylase inhibitors, what they do, they kill myeloma cells by stopping them from making a certain protein that derives fast cell growth, okay. So used in people whose myeloma has not responded or to at least 2 standard treatments. Then you have another very important new drug, that is Blenrep, that is belantamab mafodotin, that is Blenrep. So this is basically, again, important point is that is first in new class of drug called antibody drug conjugate, okay. So there is ADC, that is antibody drug conjugate. It is first type of drug which is related to the class ADC, that is antibody drug conjugate Blenrep, okay, Blenrep or belantamab, okay, belantamab. So these are used to treat patients who have been already treated with at least 4 prior therapies, including an anti-CD38 monoclonal antibody, a protease inhibitors and immunomodulators. You have given all these drugs but no response has given, then you use this Blenrep, okay. So Blenrep will target BCMA, that is B cell maturating antigen, which is the protein protecting the cancer cell, okay. So this is BCM, that is B cell maturation antigen. It is a protein which will protect the cancer cells, and this Blenrep will inhibit that, will target that BCMA, okay. This Blenrep will target BCMA. So this is another important drug in case of new drug in case of your multiple myeloma, okay. So another is carfilzomib, okay. So this is not a new drug, but also you can say it's a new drug which was approved by FDA in 2012, okay. This was approved by FDA in 2012. So this can be also a new drug. So basically it's a newer proteasome inhibitors which is irreversible, carfilzomib, okay, carfilzomib, okay. So this can also be your newer drug, and basically this drug again is important because it reduces, it has the side effects are less, its side effects are less with carfilzomib, okay, with side effects are less with carfilzomib, okay. Then you have pomalidomide. So pomalidomide is basically a immunomodulator like thalidomide. So this have been approved in 2013. So this is also normally a newer drug only, you can say. So basically this pomalidomide again can be a newer drug in case of your multiple myeloma treatment, okay. Then you have perifocin. Perifocin is basically AKT inhibitors. So perifocin, bortezomib and dexamethasone can be given in relapsed multiple myeloma, okay. The major side effects are hematological, pneumonia and nausea and diarrhea. So perifocin is again, this is also a newer drug for multiple myeloma, okay. Then you have siltuximab. Siltuximab again, it's a chimeric immunoglobulin G1 kappa light chain anti-human interleukin 6 antibody, okay. So siltuximab. So basically siltuximab is basically, it have a non-significant trend in ORR, and it has a non-significant marginal effect on overall survival of the patient, okay. Main side effects are pruritus, edema, thrombocytopenia and renal impairment. So these all were the newer drugs which you can give, which have been developed and which are developing in case of multiple myeloma. Another very important thing which is developing in multiple myeloma is basically your CAR-T therapy, okay. So now remember, CAR-T therapy, you will get one question regarding CAR-T therapy in one of your exam, either in NEET or in coming AIIMS, okay. You will 100% get a question regarding CAR-T therapy. So just read CAR-T therapy. I will take a different class regarding CAR-T therapy. It will, because CAR-T therapy is basically coming out to be a very, very important topic, newer topic, and we'll talk about this in a special class also. So CAR-T therapy is again a very, very important topic for coming AIIMS or NEET PG, okay. You will get one question regarding that. Anemia, basically you can treat by erythropoietin and blood transfusion. Hypercalcemia, you treat by saline diuresis or bisphosphonates. Renal failure, you can treat hypercalcemia, dialysis if indicated. Infection, you can give prophylactic immunoglobulin, IVIG or treatment with antibiotics, okay. So this you give as a supportive care in case of multiple myeloma, okay. Then also for constipation, you give laxatives, antacids can be given. You can give DVT prophylaxis for immunomodulator agents. Close monitoring for blood sugar and blood pressure level need to be done, and acyclovir for herpes zoster. Remember, herpes zoster, so when you give bortezomib, there are chances that there will be herpes zoster, there can be reinfection of herpes zoster can be done, can happen. Okay, so basically you need to give acyclovir or prophylaxis of herpes zoster when you are giving bortezomib. Okay, very high yield thing. So this is for the fun factor. So fun factor, see, remember thalidomide, it cost around 32,040 rupees per year. Okay, lenalidomide cost around 15,000 per cycle. And see, remember this, the newer drug carfilzomib, it cost around 5,60,000. Pomalidomide immunomodulator, it costs around $10,500, that is 5,88,000 per cycle. Okay, elotuzumab costs about $1,60,000, that is around 89,60,000 per year. Iltozumab. Okay, so that this new drug which I've done. Siltuximab cost around 49,500 per vial. Bortezomib cost around 20,000 per month, and basically stem cell transplant costs about 1.5 to 2 lakhs rupees, and this is basically 1.5 lakh to 2 years around in your government institute like AIIMS. Okay, if you go in the private institution, you are getting it in around 5 lakhs to 10 lakhs rupees. Okay, so this is a fun factor. These drugs are really very costly and for the patient, and you are not also sure that they will result or increase in the prognosis of the patient. Okay, so some other key points which you need to remember is that herpes zoster prophylaxis, it is indicated if bortezomib is used. Okay, you need to remember that neuropathy attendant to bortezomib can be decreased both by its subcutaneous. So basically bortezomib, which cause neuropathy, it can be decreased by subcutaneous administration or administration on a weekly schedule. Okay, lenalidomide requires prophylaxis for deep vein thrombosis. So when you give lenalidomide, please try to give deep vein thrombosis prophylaxis, and when you are using bortezomib, give herpes zoster prophylaxis also. Okay, so this deep vein prophylaxis either with aspirin, or you can give low molecular weight heparin and warfarin. Okay, and in patient who are receiving again lenalidomide, then what you need to do, that you need to collect stem cells within 6 months, because continuous use of lenalidomide, this compromise the ability to collect adequate number of stem cells. So when you are using lenalidomide, please collect stem cells early. So this is again a high yield point which you can be asked in your exam. So for lenalidomide, stem cells should be collected within 6 month period of time. Okay, that is again a high yield point. So this brings us to the end of today's class, multiple myeloma. So इस class को पढ़ो, basically drugs को देखो. I have tried to compile everything in this class of multiple myeloma. I have tried to compile the pathological part. I have tried to compile your part from Harrison, and I have tried to compile from drugs also. Okay, so I have tried to compile each and every point related to multiple myeloma. Just this integrate. Now just you can read your previous notes which you have about multiple myeloma, and just combine this all together at one place. Make this make a complete note at one place, and you don't need to read again and again multiple myeloma को फिर अलग अलग जगह से बार मत पढ़ो. This one lecture and one slide obviously will help you to complete multiple myeloma. Okay, so I'd like to say you thank you very much, and basically what we can do is you can just subscribe our channel, YouTube channel, and you can comment over there also. Basically you can use my promo code ANLIV live. Okay, this promo code will help you to get 10% discount, and also you can hit the like button for the notification of my further classes, even other teachers का further classes. So basically पढ़ना है multiple myeloma से questions, कैसे questions आ सकते हैं. So multiple myeloma से क्या questions आ सकते हैं. Basically आपको multiple myeloma से question आ सकता है, one related to its mutation, that is basically risk stratification. Okay, then another it can be multiple myeloma से basic question आता है जैसे international staging से. Okay, staging, because obviously most of you get confused with albumin and microalbumin. So basically alpha 2 microalbumin is basically more than 3.5. Okay, and albumin basically is less than 3.5, and the ratio of these two, type 1, stage 1, stage 2 and stage 3. So that you need to read again, go and read again, see the table again. This table obviously will help. And risk stratification, which is like good prognosis and bad prognosis, they ask most of the question regarding that. Okay, then serum protein electrophoresis. Okay, you can be given image. Okay, as I said in my basic class, go and see what type of image you can be given, and you can be asked that question in case of serum protein electrophoresis and immunofixation. Okay, so these are some of the important. Then criteria of each and every like IgM, MGUS, non-IgM, MGUS. Okay, then you have non-IgM, MBBS, IgM, MBBS. You have solitary plasmacytoma. You have basically smoldering plasma cell myeloma, or you have multiple myeloma itself. So these all are the diagnostic criteria in each and every type of disease. So that can be one more question. And basically drugs, the newer drugs and their mechanism of action, because obviously this all diseases, immunomodulators, or this all diseases like SLE, rheumatic arthritis, for that every year a lot of projects are done, lot of new drugs develops in this. Okay, for tumors and all. So basically newer drugs are basically asked from this all topic. So you can be asked newer drugs, name of the newer drugs from multiple myeloma. So this you need to know about the newer drugs. So these are the most important questions which you can get in case of multiple myeloma. Don't forget about the mutations, mutation in IgM, MGUS, mutation in Waldenström macroglobulinemia, mutation in basically, because one question will come back regarding that. And one very important question they can ask about is simple IHC for IHC marker like CD38 and CD138. Difference between CD38 and 138, you should know that in multiple myeloma CD38 will stain less darker, dimmer. Okay, so in multiple myeloma cell, whereas if it is normal plasma cell, then CD38 is staining brighter. That you need to know. Okay, and CD19 is mostly negative in case of multiple myeloma. CD19 is positive in normal plasma cell because it is a B lineage. Okay, that you need to remember. Okay, so that is basically some of the important points which you need to remember in case of multiple myeloma. Thank you very much, and see you in another class. And hope thank you for bearing me, and I'd like, please subscribe this channel, and please you can just basically use my promo code if you want to get a plus subscription or iconic subscription. Thank you. See you in next class. Have a great day.